Thank you to CONROD and the organisers today for giving me the opportunity to talk to you about what I think is a very exciting new initiative for people interested in rehabilitation in Queensland. I feel like I need to have a bit of a disclaimer at the beginning of this presentation because it's one of those talks that people look askance at in conferences, when you've got wonderful introductions and background and aims and methods. Unfortunately, the results didn't come in time, so you are left talking about results and outcomes in the future. And that's a bit where we are with the Statewide Rehabilitation Clinical Network. It's been a bit of a long journey to get here, but lots of opportunities and positives for the future. So I will tell you a bit about how we got here and what we've initially started to do. It's hard to talk about the network without talking about rehab planning in Queensland in general, and I'll just take you quickly through a bit of potted history going back to 1999, which is not when it probably started, but as far back as my memory goes now. So in 1999 there was something called the Rehab Services Advisory Panel, which was formed to develop a statewide plan for rehabilitation services in Queensland to cover the period 2000 to 2005. There was a lot of work done. Unfortunately, for various reasons, the plan wasn't endorsed or officially implemented. But around about that same time, there was a lot of work being done for planning around trauma services as well. As it always has been, the Motor Accident Insurance Commission was right in the middle of this, pushing it along and providing funding and providing the ability to do some initial planning around trauma in Queensland. I was on that steering committee, so was Nick Bellamy, who was then the director of CONROD. And what came out of that was called a trauma plan for Queensland. And as you can see down the bottom there, there were a whole range of issues that were being addressed, including rehabilitation. And I think we've been lucky in Queensland in that the people involved in trauma services have by and large always seen the importance and the value of rehabilitation. So what came out of that was this document, a trauma plan for Queensland. I won't go through all of the issues on the right. There were a whole range of recommendations made around rehabilitation services. You'll see some of them there, taking a statewide approach, building up brain injury services, looking at adult services and looking at service developments in various parts of the state that were known to be missing at that time. All very reasonable kind of things. Unfortunately, as the trauma plan went forward, the rehabilitation component didn't go forward with it, again for various reasons that I won't go into today. But the planning work that was done then was really vital as a springboard for future planning and future understanding of the need for rehabilitation services. Also around about that time, there was a lot of planning starting to be done between Queensland Health and Disability Services Queensland, as they were then, looking at a whole range of other issues for people with disability in Queensland, and that again was a very important component of the planning that had been done. And then that brings us to around 2006. And there was something then called the Rehabilitation and Sub-Acute Services Reform Initiative. And as part of that initiative, there was a statewide rehabilitation clinical reference group developed. And if you look down the bottom there, so what was that group going to do? They were going to develop a statewide rehabilitation plan. They were going to work with area health services, and ultimately they were going to form a statewide rehabilitation network. And I think that that's probably the first time those words were officially used. So what are these networks? What do they do? Where do they come from? They come right back from really the Forster Review that was held after, that was commissioned after some of the problems in Bundaberg. And what came out of that was a renewed emphasis and interest and understanding of the importance of working with clinicians and getting clinicians together in groups. Initially they were called collaboratives, and then at that time the clinical network was defined as a formally recognised group principally comprising clinicians established to address problems in the quality and efficiency of healthcare. So at that time a number of initial networks were set up. You can see them there: anaesthetics, cancer, dementia, diabetes, a whole range of common common and important health problems, mostly at the acute end of the health spectrum. Coming out of 2006, 2007, 2008 was the more intensive work done to develop the Statewide Rehabilitation Services Plan. And this went on throughout 2007, 2008. Again, a lot of time invested by a lot of people all over the state, a very collaborative, intensive process to develop what was a good plan. They are the objectives, the headings of objectives that came out of the plan. So increase inpatient rehab service capacity, establish a statewide network, establish formalised rehab networks in each area health service, expand the capacity of outpatient and community services, expand specialist services, so in that they were referring to brain injury, spinal cord injury, similar things, expand availability of rehab support services, build capacity of the workforce, improve information management and adequately fund services. Again, all very reasonable and important things. This is just a snapshot of a couple of pages of the eventual sort of objectives that came out of that plan, just to give you a bit of a sense of where we were. So we needed, the assessment was that we needed to increase rehabilitation bed capacity by about 270 inpatient beds at that stage. That was sub-acute beds. Approve and establish a rehab network. So again, looking at outpatient and community rehabilitation services, and then getting into the specialist areas of service development around spinal cord injury, brain injury, and these covered the whole gamut from inpatient services to community services, paediatric rehab services, and burns. And then looking at some of the support services, and then getting into issues around the workforce and information management. Quite an intensive process, a good process, talking to lots of people and getting lots of input. So the plan was completed in about 2008. Funding wasn't specifically allocated to the plan at that stage, and I think one of the problems over the years with rehab planning is that when you start to sit down and add up the potential cost of developing services, it looks like a very daunting task. Many of you are probably aware that in 2010 the then federal government announced these national partnership agreements, and there was one around public health service, particularly looking at sub-acute services. So there was about $300 million over 4 years that was allocated deliver and operate a minimum of 265 new subacute beds or subacute equivalents. But just remember that subacute includes rehabilitation, geriatric evaluation and management, palliative care, as well as transitional care and other sort of community rehab similar services. But that was a great start, and that allowed the development of quite a few new rehab services, as well as infrastructure, workforce improvements, staffing improvements. And that brings us to 2014, when there was a review of that statewide plan, of the previous plan. You can see down the bottom here, they reviewed all the strategies that were in the original plan. 10 had been completed, 37 partially progressed, and 22 not progressed. And the areas of progress in general terms were around inpatient beds, physical environment, community rehab services, and workforce initiatives. And they described more limited progress around a statewide network, support services such as rehab engineering, and more specialist services. So throughout 2013 and early 2014, the Queensland branch of the Australasian Faculty of Rehab Medicine continued to work to try and get a rehab clinical network established. And so what do you have to do to have a network? What are the rules? What do you have to sort of fulfill to have a network? Certainly there's a need for the problem that you're dealing with to have a statewide impact and be a significant clinical area. They need to look at, is there overlap with existing statewide networks? And then also the potential for collaboration and working together between different networks. And so also they want to make sure that the network is going to be a success. So the commitment and enthusiasm of key stakeholders, strong clinical leadership, willingness to focus on service improvement and measurement and benchmarking, bringing together a whole range of relevant stakeholders, and the recognition to work beyond institutional boundaries. Networks need to articulate the challenges of delivering services at the front line. Networks are involved in redesigning the patient journey so that it's safer, more effective, more appropriate. Also need to identify areas that warrant escalation, as well as being an important communication conduit between government and clinical services, as well as developing policies and pathways, looking at decision making and redesign, being politically astute, and advocating for rational resource distribution. So that brings us to May 2014, where there was an initial meeting held with the Clinical Access and Redesign Unit, or CARU, within Queensland Health, to start talking more seriously about the possibility of a network. And finally, in October last year, approval was given to establish the network. So it was established within the Clinical Access and Redesign Unit, which is responsible for all the clinical networks. It's recently changed its name. It's now called the Health Innovation Unit. Where we are with networks now, the ones in the black were the original ones. Since then there have been a number of new ones. You can see child health, communicable diseases, general medicine, older persons, rural and remote, and surgical, and finally there also rehabilitation. This is what the Health Improvement Unit now says that clinical networks are about: improving patient outcomes and processes of care by connecting clinicians across the state. So the vision is to engage and integrate and empower clinicians to innovate for service improvement, to embed evidence-based practice models, and to set and monitor clinical standards. And then the purpose As a peak body of expertise in Queensland, the statewide clinical networks serve as an independent, I think that's important there, an independent point of reference for clinicians, hospital and health services and the Department of Health. So they guide quality improvement, they support clinical policy development, they emphasise evidence-based practice, they try and get clinical consensus to guide implementation, and they optimise and try and undertake optimisation and provision of high quality, patient-focused healthcare. I wanted to call this slide Better Late Than Never, but I was told perhaps 8 years in the making was a better title. But I think that no matter how long it took, this is a very important step and development for us. So we have a steering committee that's been established. I'll talk a bit more about that in a minute. So the steering committee's role is to provide direction and leadership to the network regarding the ongoing and future development of best practice evidence-based rehab and rehab services in Queensland, and provide expertise, direction and advice to Queensland Health Executive in relation to rehabilitation and rehabilitation services. So we have co-chairs appointed myself. This only happened in early 2015. Ben Chen, who some of you may know, is the Director of Rehab at Gold Coast, and he's the other co-chair. We have a network secretariat provided by Greg Carrigan, and he was only appointed early this year as well, and so we make up a small network executive, and we did some initial planning to set up the network. We had a call for expressions of interest for the steering committee around February this year, and I know that some people in this room put in an expression of interest. I think you can see from the number of expressions of interest that we received, almost 50, that there is a strong interest in this area and in the network. So I apologise to people who didn't make it onto the steering committee, but there will be turnover, no doubt, in the future. As part of that expression of interest, we also asked people to comment on what they thought their priorities for the development of rehab services was. So the initial membership of the steering committee was finalised around April this year. We had our first meeting in May. We had our first face-to-face meeting in July, and the plan is that we will meet monthly. So you can see that things are still very new and young. That's the membership. I won't run through everyone. Just to give you a sense, we've got people from pretty much all over the state. We've got a mix of medical staff, nursing staff, allied health, physio, OT, social work. We have not got a consumer rep yet, but we are in the process of looking for someone. And there's probably one more spot that we can have on the steering committee as well, and we are concerned that we probably don't have best representation from sort of rural and remote areas and from nursing. What do we need to do as the steering committee? We're supposed to reflect the diverse and broad range of stakeholders and clinical expertise. We need to be looking at involvement of across other networks, and we have some clear collaborations potentially around trauma and stroke and older persons and the older persons network. We need to meet and do something. To some extent, we need to think about the priorities of government at the time. The networks are clinically led and directed. The agenda's based on needs or deficits. And there is a sense that we need to be working in the context of alignment of the broader health initiatives and imperatives. In the simplest terms, we're looking at service delivery and identifying gaps. We need to be patient-focused, person-centred. We look at policy, performance, and particularly redesign and models of care that may be more efficient and provide better outcomes. We do have some backfill for the time of the co-chairs, and we have some secretariat support provided by CARU and the Department of Health. We have limited funding to cover travel costs of people who need to come to meetings from interstate, from other parts of the state, and we have some funding to be able to put on, to do particular projects, put on forums, workshops. That's Ben Chen, my co-chair from the Gold Coast. General membership of the network, we've currently already got 70 people on our email list, and that's really without trying. The membership will be multidisciplinary, as we've said, and include consumers and non-government organisations. It's voluntary and open to all individuals and groups that express an interest. Seeking more members, and we're at the moment working on a communication strategy. We will be having second monthly newsletters, and we've got a website, our website, which is under development. So we will be getting a lot more information out to everyone over the next few months. As you can imagine, rehabilitation being such a broad field, and with a scope of things which is pretty enormous, trying to identify priorities and what we tackle first and how we move forward is an important thing. So we've been thinking about how we do that. We did get the initial feedback from the expression of interests that we sent out for the steering committee. We've obviously got all of that previous rehabilitation planning, most of which is still very relevant and important that we can look at. We've had discussions within the steering committee ourselves, and we will be doing some further consultation broadly to try and narrow down what our priorities should be. And the last category there is things that fell into our lap that we didn't have much choice about, and that's not meaning that they were bad, but they're just unexpected or unplanned for. A grouping of all of the priorities that people identified when they put in their expression of interest to be on the steering committee. I think if you scan that list, it's a pretty good representation of the sort of areas that you would think about we needed to be covering: equity of access, quality and benchmarking issues, policy, governance, research, data collection, promotion and building people's understanding about what rehabilitation is. Particular clinical areas of rehab people are interested in looking at more closely. And so all of those things, I don't think there's anything particularly unusual there. If we look a bit more at the existing, at that review from 2014, a number of things stood out there, particularly around inpatient bed numbers, but also around outpatient and community rehab services, the specialist end of the spectrum, spinal cord injury, brain, paediatric, burns, and then some of the issues around workforce development and data management. One of the things that we are already in the process of doing is that there was a document called the Rehabilitation Resources Directory, which was put together a few years ago, which tried to compile information about every rehabilitation service in the state. And people found this a really useful document as far as knowing what was out there, what services they provided, and how to contact them. And so we're going to do a review and updating of that document. I'll give an early plug to our Rehabilitation Forum, which we're holding on the 27th of November at the Royal Brisbane Women's Hospital Skills Development Centre. And prior to that, we'll be having a data workshop where we'll be working with AROC, the Australian Rehabilitation Outcome Centre, to start to do some initial work about our outcomes, our existing outcomes, and there's potential there for benchmarking if that's the way we decide to go. In the category of things that fell into our laps, I will put the statewide brain injury rehab services plan and the statewide spinal cord injury health plans, which have been going on for the last planning processes, which have been going on for the last 12 months. And it looks like these will be handed over to the network to continue to work on when the plans have been finished, which is a good thing, but an unexpected thing. I'll just mention the Queensland Clinical Senate, and I think this is another important fact about having a network, and that is that the co-chairs are part of the Clinical Senate. So the Clinical Senate is a peak body of clinicians and consumers in Queensland that provides information directly to the Minister and the Director General on strategic health issues. So that's an important thing for rehabilitation, to have a voice at that table. What's the future? We're still relatively early days. We are wanting to increase the general membership of the network, and we will be getting information out there. If you're not on the mailing list and you would like to be, please contact one of us. We need to finalise the steering committee membership. We're working on the rehab forum and the data workshop. We need to embed communication processes, and we need to finalise the initial priorities and establish the network subgroups. So I think it's an exciting time for rehabilitation in Queensland. While it's arguable that rehab and subacute services have been slower to develop in Queensland over the years, there's been a lot of work and progress and improvement over the last 10 years or so. On the right there is just graphs showing the increase in the number of rehabilitation physicians and rehabilitation trainees in Queensland over that period of time, and I just use that as an example of the growth and development of rehab services, which has occurred. That's not to say that there isn't still a lot more work to be done, and I think the clinical network will be a very important catalyst for making sure that service development and improvement does continue in the future, so that we can get the best possible outcomes for people with disability in the state. Just an acknowledgement for Greg Carrigan, who helped to put together the presentation. Thanks very much.